Hi everybody, let's get started. We've been anticipating this day of SMILE approval for quite a long time. I've been involved from its inception for about a decade. We've had 2 clinical trials where I had the privilege of performing the first SMILE procedure after FDA approval, and now the time has come to introduce this procedure to you so that you can refer your patients, hopefully, for this in the near future. So what is SMILE? It's a small incision lenticle extraction. A lot of people think SMILE is kind of a funny name because it reminds you of a dental procedure. But what's done is one single laser cuts a lens-shaped piece of tissue that's removed from the cornea. And this only takes 22 seconds to create this lenticle. It's called a lenticle because it's a very tiny lens. And then there's a very micro incision, kind of like arthroscopic surgery, through which the tissue can be removed. So this is less invasive, less structural weakening, and has a lot of long-term potential benefits. Most of the corneal integrity of the outer layers, where most of the strength, as you know, is maintained, and there's much less corneal nerve damage than either LASIK or PRK. So this is a femtosecond-based laser technology. I first performed it in 2006 with a German medical license they arranged for me through Zeiss when I went over to Germany and actually did early procedures with this, with early prototype lasers. And since 2007, I've been a consultant with Zeiss for the VisuMax in the US. It's a great laser for doing flaps because it cuts the same curved contact glass type shape, which allows for a very gentle flap to be created. But then I became the medical monitor of the clinical study, and first we did a clinical study for sphere only, which had limited approval about a year ago, and now finally in 2018 we've got full approval for SMILE and a full range of myopic corrections, and we'll go over that later, but we can basically correct about 95% of all myope patients that would be candidates for refractive surgery. So why do we need a new procedure? Well, LASIK, as you know, is pretty good, and you guys have all been sending us thousands of patients for LASIK and PRK over the last 20 years. LASIK has evolved and become much better than it used to be, but still requires a flap with a small hinge, so a lot of corneal nerves are cut. Also, on higher corrections, since there's a lot of pulses put in, there's some variability in the treatment. And there's the healing response in both LASIK and even more in PRK, where you have to watch the patient carefully, make sure they don't have any wrinkled flaps, they don't rub their eyes, they have to wear goggles, and there's some degree of dry eye issues with both of these procedures. This slide has already been updated. There's now over 1,000. So how do you select which patient should be for SMILE versus other things? Well, one thing is we can give you some literature that you can look at and also share with your patients, comparing the different options. SMILE is approved for up to 11 diopters of myopia and up to 3 diopters of SIL. And as I said, that accounts for about 95% of all your myopes. It's a great solution for people that are in the armed services, that have contact sports, very active sports, and millennials particularly seem to find this a great option. They like the idea of the fast recovery, not having to worry about rubbing their eyes, wearing eye makeup, things like that, and just less interference with their day-to-day routine. So they're sort of a good target group for this procedure. But like all medical procedures, they all have risks, LASIK, PRK, as you know, and also SMILE. There's a chance, very rare, we fortunately have not had this, of an aborted procedure where partway through the patient were to squeeze their eye and break suction, and that would result in us not being able to complete the procedure in certain cases. Others we can go back and complete it, but there's a very small chance that a patient might start out having SMILE, but we might need to either do nothing or switch them to a different procedure. For that reason, we want to be sure that we don't have patients that are squeezers, and you should not recommend patients who are extremely nervous, who cannot keep their eyes open, and you know who those people are. Other risks are very small. You can have a torn lenticle, removing the lenticle, haven't seen that. Decenter treatment is very rare because the patient helps to center the procedure. There can be a small amount of debris or epithelium in the interface, which is also rare and usually not consequential. However, this is a real surgery, and it does take some training and skill to be proficient at it, so you need to refer patients to doctors that have good experience with doing this sort of thing. The other things that you need to be aware of as far as downsides is sometimes there's an initial sharpness delay where vision's usually good at one day, and usually it's 20/20 or better, but some patients have 20/25 or 20/30 vision at one day, so you don't need to refract people at one day. Basically, if they say they're pretty happy, even if their vision's a little blurry, just reassure them that it should get better, and when they come back at 1 month, they should have excellent and stable vision at that time. And also the other downside is at this time, because it's this micro incision, we don't have a flap to lift, so in the rare instance, and we've only had 2 patients so far in all this time that needed an enhancement, but enhancements at this time need to be done with PRK. So what are the results? Well, at 6 months, almost everybody is 20/40 or better. At 12 months, you can see here 99.7%, just like at 6 months or 20/40 or better. And if you look at then the better acuities, 95% at 6 months, but up to 97% at 12 months or 20/25 or better, and 87% to 88% 20/20 or better. And even at 2016, 2 out of 3 patients roughly at 12 months can see 20/16 or better. And this is pretty amazing when you consider that many of the patients in the trial were higher myopes. A lot of people that were done are in these -8 to 10 range. So to think that you could have people that are -8 or 10 with 3 diopters of cylinder and still have a high percentage of them 20/20 or better is really very, very impressive. So let's talk a little bit about managing SMILE, the results. A retrospective case series in which patients underwent SMILE for the correction of myopia and astigmatism looked at over 3,000 eyes. And in those cases at 6 months, they found, similar to what we saw in our study data that I showed you, that 99.8% of them were 20/25 or better. And this is about what we expect in the real world. And usually 20/25 or better in each eye translates to 20/20 binocularly. So these are virtually 100% of patients seeing well enough to drive and do all of their daily functions without any help. They had a small percentage of what they called intraoperative complications, but virtually all these resolved. These were fairly small, minor issues that they pointed out. And this is in the Journal of Cataract and Refractive Surgery in June of 2017, if anyone wants to go look this up and see all the details for themselves in a larger study than what we had in our clinical trial. Excuse me. So what will you see when you look at these patients? Well, at 1 day post-op, you're not going to see very much. You're going to see, if you look up under their upper lid, you'll see a tiny superior incision. And if you look carefully with the slit lamp, you'll be able to see where the edge of the lenticle was, since it has a thickness, as I mentioned, of 15 microns. And you may be able to see slightly the edge of the uppercut, which is a little larger in diameter and begins at the exit area of the superior incision. But remarkably, you won't see very much at all. If you look at these with ultrasound, we can identify all these same landmarks, and the cap cut is routinely 120 microns thick on these eyes. We want the cap cut to be a little thicker than in SMILE. The philosophy is different because here we realize most of the strength in the cornea is in the outer tunic area of it. So by keeping the cap a little bit thicker, we maintain more of the corneal strength and then remove the lenticle from deeper within the cornea where the strength isn't so great, although we still try to respect, and we do respect, the 250 micron minimum bed thickness. Typically we make these at a 6.5 millimeter diameter for almost all patients, but if there's a high myope with a thinner cornea, we can do 6.0 millimeter diameter, and that results in an extremely good result with really not much of a problem at all. You have to worry, of course, about nighttime halos and glare for patients that have extremely large pupils, but we really haven't seen this as a problem in our clinical study. And because the centration is so good and the shape of the lenticle is so good, very few higher order aberrations are developed in this procedure, less so than in LASIK or in PRK. So why should you refer your patients for SMILE then? I think we've kind of made some good points here. From a marketing standpoint or a business standpoint, also for co-management, this is pretty much an exclusive market between yourself and the limited number of doctors that are doing this procedure. So you don't have to worry that patients are going to go around you and go see some discount LASIK center. That's not to say you shouldn't send them for LASIK if that's the best procedure for them, but if they are a good candidate for SMILE, you have better relations with your patients, and I think that it brings us back to the way things were back at the beginning when we first started doing LASIK, and we had such great co-management relationships without all these other discount LASIK centers around. Also, you can be sure that patients that you refer are really good candidates for this, and it's really best for your patients to have your care supervising them for any of their eye care needs. It's particularly good for first responders such as the military, police, firemen, people active in sports, as I mentioned. And it's the next step in refractive surgery. I think that this is a paradigm change. This is the first generation of this, but it's already great. And as time goes on into the future, SMILE will be the thing that more and more patients are having. Other manufacturers besides Zeiss are actively looking into this. There will be other lasers that do the same thing, and you will find that this is something that will become part of your practice and the general refractive milieu. So the biggest things, though, are the minimal risks of postoperative problems. You don't have to worry about wrinkled flaps. You don't have to worry about patients rubbing their eyes. Although it's not an approved indication, we've seen a lot less dry eye problems and dry eye complaints. In our study, we did one eye SMILE and one eye LASIK, and the patients had not quite as good a result, both in terms of their vision with their LASIK eye, both short and long term, but also we saw a lot more dry eye problems and things like TLSS in the LASIK eye occasionally, but never saw it in the SMILE eye. And although enhancements have to be done with PRK, you're going to find a lot less enhancements in these patients. The enhancement rate is well below 1%, and that's going to be more efficient use of your time. So here's the reasons why we SMILE, haha. Safety number one, they don't have to worry about a flap. Your patients, as we mentioned, no nighttime goggles and makeup right afterwards, get back to their lifestyle. Corneal integrity is better, all those sorts of things. The predictability is actually better than LASIK. It's one laser. There's no nomogram adjustments. There's no external intraoperative factors to take into account. The laser, when it was last tuned up, the humidity, the temperature, the corneal hydration, all these things that we have to take into account with LASIK and PRK just aren't a factor here. We haven't seen regression even in high myopes. Some of our LASIK patients that are high myopes, you've probably seen some of these, where even if at 1 day or 1 week they're 20/20, we unfortunately see some of those patients come back at 6 months and they are back to being a -1 or something like that. So we don't typically see both either over or under corrections, and we just don't see regression, and that leads to this low enhancement rate. And our uncorrected distance vision in the long term is really comparable to our LASIK results, which has over time been very good, but especially for high myopes, I think this is something that if you have a patient that is a higher myope to take into account, because it preserves the anterior corneal nerves, and there's virtually no pain after this. We ask patients, even in the LASIK versus SMILE study, patients had some discomfort in their LASIK eye, very little, but a little bit. They said they felt virtually nothing in their SMILE eye, and it's probably because of the tiny incision and less cutting of corneal nerves. And there's very less dry eye in the postoperative period, which is really a very important factor, as you know, in refractive surgery. And we see less dehydration and microstria. And microstria, although they're improved by epithelial remodeling, if you don't have them, you're going to have the very best possible acuity. So let's look at preservation of visual acuity at night. We look at higher order aberrations, as I mentioned. There's less of these created. They're really not changed much from the pre-op, whereas we see more change in higher order aberrations in LASIK and in PRK. And here you can see a patient where one eye had SMILE, the other eye had LASIK. They're both pretty similar, but if you look, the left eye had LASIK, and you can see sort of a bigger transition at the edge of the ablated side, and it's not quite as perfectly centered, even though there's an eye tracker, whereas in the SMILE eye with the same size optical zone, the same 6.5 optical zone, it appears that the treatment area is larger, it's more centered with the pupil, and there's less of a transition between that and the untreated cornea. And these factors may result in just a little better quality of vision. So, kind of in conclusion, this is really a new vision for us, and after performing LASIK over 20 years, a new paradigm. I think it's a wonderful new opportunity for co-management. It's really a great solution for patients. I think patients are the big winners here. Again, I would recommend that you allow us to make the final determination on surgery day. We do some additional tests beyond the ones that you do, and we also evaluate the patient on some other factors. And most of the time, if you recommend SMILE, that's what we'll do. We can contact you ahead of time to talk with you if we think something else would be better, or we can just, with your permission, make that determination with the patient's consent. And we really look forward to moving ahead with all of you who've supported us over these years. We're, of course, going to continue to do LASIK and PRK in large numbers. There are patients beyond the refractive range of this procedure with higher cylinder. There are patients that have too thin corneas. There are patients that are squeezers. There are patients that have slightly irregular topography where we're not ready to do SMILE on those patients at this time. There are patients with other medical considerations. There are patients who've decided that they want to have LASIK because 10 of their friends or family have had that done and they don't really want to consider a different procedure. So there's all kinds of reasons why some patients, even if they could have SMILE, may not have it done. But we think that over time we'll gradually be doing more and more of these. And we wanted to introduce you to this procedure and help you to understand how it can impact your and our practice together. So I hope this introductory presentation did exactly. There we go. Let me play this video from Zeiss that goes over what this procedure is and helps you to understand it from a diagrammatic standpoint while you gather your thoughts and decide to send us information for questions that you may want us to answer for you. This goes over the major points, that this is a flapless procedure and how it works. You can see that it's not cutting nearly as much as a flap would be. And this video is available with overlying audio available to you and your patients to help explain the procedure, and we can make this available to you as well. Kind of reviewing all the things that I've spoken to you about. Here you can see the actual laser with the contact glass attached. And it's all done femtosecond laser, very high tech, kind of like an open CAT scanner. Typically these patients' treatments take about the same amount of time as a LASIK. The patients in the operating room for about 15 minutes. And that's just like the video I showed you. So thank you very much for taking the time to watch this presentation. I think this is the most significant advancement in laser vision correction really since LASIK. And it's probably over the next 20 years going to become the dominant procedure in refractive surgery. It's one step, it's one laser. And here at Dishler Laser Institute, I have to brag, we're the first to perform SMILE in all of North America. We've been involved in this and many other procedures with refractive surgery and clinical trials over the years, as you well know. We're the regional authority. We train other surgeons who come to see our center and watch and learn how to do this procedure, as well as all of our tips and pearls of how to do other procedures. And we're the most experienced, and we've, for the longest time, have been working with co-management in laser vision correction. So please feel comfortable and confident that you can refer your patients to us and that we will take good care of them and give them whatever is in their best medical interest and help us to find out if SMILE is the right choice for you and the right choice for your patients. And with that, I want to thank you all very much for spending this time with me. And we'll adjourn at this time. And please stay in touch with us if you have any questions. Thank you very much.